I can close that even now.
There you go.
Yeah.
That's
Hello. Welcome everyone to today's Endocrinology Multidisciplinary Grand Rounds. So we are very pleased to have today with us Dr. Tim Ford, who is the Chief of Podiatric Medicine and Surgery at UofL and at University of Louisville Health. He also is the Associate Professor in the Department of Orthopaedics. He's the Director of the Podiatric Medical Education Program, Fellowship Director for the Reconstructive Foot and Ankle Surgery, and also for the Podiatric Residency Program. He has been very active in the field of podiatric medicine, both locally, regionally, and also nationally. He has been the past president of Region 13 of the American College of Foot and Ankle Surgery. We all know him through being people who deal with diabetes, have referred him many patients, and we have seen many of his patients in the hospital and also in the clinics. So we share a very common group of patients who need a lot of care, and he has been published in this field and also is currently a co-investigator on one of the studies that Dr. Sufan Shen has been PI on from the NIH, looking at dressings for diabetic foot ulcers. So today he will be talking to us about diabetic foot and what we can do in terms of prevention and treatment. Thank you, Dr. Ford.
Thank you so much. All right, everybody. I think everybody can hear me. So let's go ahead and start. So first of all, I'd like to talk a little bit about the diabetic foot and where we are with endocrinology and our service line. And I think there needs to probably be a little bit more merging with us because we all have complex patients. We all need each other's services. So this is a great topic for us to keep going and going through this thing. Let's start our slides. Let's see if we can get this thing running. Inside?
No, just inside. There you go. Now.
Me. Not the roundabout, this guy?
Yeah, and then
that? There you go.
Yeah.
Okay. So why be worried? So we should be worried because of the next slide I'm about to show you. So diabetic foot lesions are responsible for more hospitalizations than any other complications of diabetes. You should all realize that. It's the leading cause of non-traumatic lower extremity amputations in the United States. 5% of all diabetics developing an ulcer and 1% requiring amputation. So here's our map, and look where we're at. We're in the hot zone, right? So south is bad, and so you get out to South Dakota, Utah, Colorado, not so bad, Alaska, but we are in the hotbed, and hence is why we see a lot of these patients. And a lot of them aren't great patients. A lot of them don't follow our instructions. A lot of them don't do. And I just had a conversation with one of the fellows a second ago because I said my normal hemoglobin A1C for some of my patients that come to the university is around 17. We're in double digits. So we know that's not good and they're not really well controlled. So what I'm going to talk about are some factors, risk factors and foot statistics, and give you my top 24 list, okay? So the first topic is diabetic foot ulcers and amputations. The second topic will be risk factors for diabetic ulcers and diabetic foot ulcers and infection. And then finally, peripheral arterial disease and diabetic foot ulcers. That one I did with Dr. Diabetic. So here we go. So a foot ulcer is the initial event in more than 85% of major amputations. So people who get a foot ulcer, they're ready to go and prime for some sort of amputation. In the United States, that's how many amputations occur in the lower extremity, not related to trauma, all related to diabetes. Throughout the world, every 30 seconds, a limb's being amputated, to give you an idea, related to, again, diabetes. 10% of the population have diabetes, have a foot ulcer. So, staying with diabetic foot ulcers and amputations, the lifetime risk of developing a foot ulcer for someone with diabetes, 25%. Every year, that's how many people get a new ulcer. So it keeps just gravitating. These are the ones that don't heal, 10 to 15%. Of the diabetic foot ulcers that don't heal, 25% require an amputation. So now you're at that 0.25% of all your patients. Not good. In one study, research showed that following an amputation, up to 50% will die within 2 years. And that's because of cardiac overload, and we all should know that, right? Get a BKA or an AKA, it really strains the system. So this is how much it costs, and this isn't a problem for the United States. We're talking billions and billions of dollars for diabetic foot wounds. This is the number. It's amazing. 20% of the hospital admissions for diabetes are due to foot ulcers, so almost a quarter of them. And then after a limb amputation, someone with diabetes will remain in the hospital for that long, which is straining the system. So it is a system problem as well. So when we talk about risk factors for the diabetic foot ulcers, we should know what these risk factors are. Okay, neuropathy is one. Okay, it makes sense, right? They can't feel, they don't know they have a sore. Many of you will take their socks off, they don't even know they have broken skin and a wound present. So it's important for us to talk about that. We'll get to that later on in the topic. Peripheral arterial disease is the next one, right? So that affects almost the next half. And so you notice it's neuropathy and it's arterial disease. That tends to be our problem. Over the age of 60, more likely to develop a ulcer. And waiting to be seen. If it gets out longer than 6 weeks, it will result in an amputation. So you got to get them in fast. So the longer they wait, the longer the chance this has to get to the bone, gets to the bone with osteomyelitis, and then new things become problematic. So risk factors for diabetic foot ulcers still. So number 17, look at what happens when you have a team approach to diabetic foot ulcers. You get it decreased by 75%. So the risk of amputation drops immensely from almost 100% to 75%. So we're doing great. So, and you look at number 18, okay, up to 50% of the diabetic foot ulcer cases can be prevented with appropriate education, which all of us should be doing, right? Talking about their hemoglobin A1C, talking about tight glucose control, talking about nutrition, things that we don't give them enough about, and following up with better labs like albumin levels and things like this to really give them a better idea of where they're at in space. And are they doing the things that will allow them to heal over time? So diabetic foot ulcers and infection. So remember, if the longer it's out, the more likely it's going to become infected, right? So these ulcers that get to be 20, 30 days old, high likelihood they're going to get infected. And then osteomyelitis is seen in about 15 to 20% of the people with these foot ulcers because they're chronic. So the goal is to close wounds. The longer they're open, the longer they have and better chance they have of getting an infection and getting an amputation. So our goal is to try to get these closed fast. So here's some more data on peripheral vascular disease that I got from Dr. Diabetic. After 1 year of peripheral arterial disease treatment, so some sort of intervention, you get almost 90% of limbs affected with foot ulcers would be saved from amputation if we can get them in fast enough. You know, we have a lot of smokers, a lot of ischemic limb patients, but if you see them initially and you know you don't have pulses, we got to get them to the vascular guys so they can go ahead and open these guys up. So it's imperative, nothing will heal. So like I say, you need to have flow to the toe, right? So no flow to the toe, you got problems. So that's it, 22, okay? It's estimated that 60% of the ulcers in people with diabetes and PAD are healed once they have treatment done, all right? And so here's my sources, and it's a long laundry list of different places, everything from the United States Health and Human Services to diabetic care, plenty of things, and diabetes research and metabolism research. So a lot of resources for you to look at. This is where we're at today here in Kentucky, right? This is our evolution. We started nice and healthy and stealth, and now we got supersized sodas and weighing 100,000 pounds, right? So this can't be good for anybody with diabetes. So what do we do? So we talked a little bit about neuropathy being an issue. So we have to test their neuropathy. So we test them with a simple thing called a Semmes-Weinstein monofilament exam. This was done in a Hansen clinic. Believe it or not, there was one in a place called Carville, Louisiana. the only one in the United States. It closed approximately 15 years ago. I went there to see it. Brilliant people there. They're the ones who developed this, actually have the original one they were using there. So it tests 10 grams of force. This is just put up against the foot. Multiple areas around the foot are tested, and it will tell you if they have a problem with sensation and are they at risk to ulcer. That's a great test and simple and inexpensive. Everybody should have one. Other tests that you can do. Pressure control. You can put leads on like this and have them walk around an office, look like a Holter monitor around their waist. And to the right-hand side of your screen, you can see that pressure map showing you where peak pressures are. So that purple and red are all peak pressures, black and green, nothing. So you can see there's a lot of forefoot pressure going on this individual. The arch, you can see where it is. And here's our little arch right here. This would be the first metatarsal, and this would be the fifth metatarsal. So, and we could test it this way, and that's how it's tested. So when you do have excessive pressure, you get relative tissue anoxia. More mechanical stress will lead to breakdown of those tissues. So pressure is bad. So one thing we have to offload. So here's a way of offloading things. I don't know if you can really see it down here, but this is a platform and this is a heel. And so the forefoot is just floating out here. So it eliminates pressure off the forefoot so people can walk with a forefoot ulcer. That means one's in the ball of your foot to alleviate pressure. So we have to find ways of getting rid of pressure. Shear force is bad. And anybody knows about force? Shear force is the sliding force that you see across your shoes, right? You can eliminate that with other materials that flow. So silicone materials, things like this, eliminate shear force. So it's important to have these things. Neuromuscular things are always a problem. But I will tell you, for the most part, we always try to find ways to offload the foot. So VACs, everybody seen any of these things? Does anyone have an opportunity to see it? Okay. So remember, we have gases all around us. It's putting pressure on our surface all the time, including our body. This dissipates it. It does a few things that are really good for wounds. It pulls the wound edges together, which is great, and it also takes fluid off the wounds. So we use a lot of these in ulcer care just to try to get these things to close down fast and get hypergranulation tissue over it so we can put skin on it, okay? And we'll talk a little bit about that too here in a second. So other things that remove pressure. This is what's called a total contact cast. Use this up here at our wound care center. That's at the Heart Hospital on the 6th floor. Total contact casts are actually applied directly to the patient, not any padding, only on the front part where it's just some foam. Molded exactly to the foot with the brace that you see kind of going on. So there's the cast, here's the brace. And it will offload most pressure. It's not all of it, but about 70% of it is offloaded through this. So we use a lot of total contact casts. They're labor intensive, but still they work extremely well as far as healing wounds. We use these because people can take other things off. Patients are not very compliant. So when we have fairly non-compliant patients, this is a way to make them compliant because it's hard to cut a cast off, right? So they're not going to get this guy off of themselves. Shoe pressures. Here's a great picture. I took this one in my office. You know, you got to be careful of shoes because it can create different forces and vectors and pressure. Here you see female with very narrow toe box, and this is what a foot looks inside it. So you know it's going to create a lot of pressure. I love this thing. So thermography. Thermography was by a guy named Larry Laverty and a guy named David Armstrong. They were down in San Antonio, Texas, at the University of Texas Health Science Center down there. And they use digital thermography, which is great. And it can test, it's a laser, you know, just get close to anything. By the way, you can buy these over at Home Depot. You don't have to get anything super fancy. Just have to calibrate it to your skin and test, and then you can use that against other people. What we try to use these things for is to differentiate people who have Charcot and people who have hot spots where they might develop an ulcer. So believe it or not, we can take this, put it up against their skin where there's a little erythema there, and then test their other side, same spot. And if there's a 2 degrees Celsius difference, we're like, this is not good. This is about to break down. So we try to get it before it happens. So it's another system, an inexpensive way of doing things. If anybody drinks wine, you can test your temperature of your wine bottle, right? So here we go with wounds. I know everybody's favorite, they don't want to see this stuff. So types of wounds. So there's pressure wounds, diabetic, vascular, traumatic, right? So we're kind of going to hover right around this area here, right on the diabetic side. So remember, chronic wound is anything that doesn't heal after about 30 days. And this is from the National Institute of Health of how much chronic wounds cost. Now, this is not just diabetics. This could be non-diabetic, could be a vascular, could be a traumatic. Remember, we're 11 billion just on diabetic ones. So we'll add another 14 to that. Yeah, crazy. So just a lot. Wounds, they can be caused from anything. So this is a ram's horn nail. This is where I cut it at. So the nail is coming from here all the way around here into this little smiley face, making a giant ulcer. Yes, that big. This was a homeless individual who had diabetes, came to our clinic and had this crazy looking nail, toe all puffy, and this is what you end up with. Yeah, we took the rest of it off, but I like to get the picture so you can see how crazy and how extensive these things are and what it can do to patients because they can't feel anything. So those of you who treat any of the homeless community here, they don't like to take their shoes off. They don't want to do it because of what? Because someone's going to steal them. And then they're going to have their pair of shoes. So they want to keep them on, okay, which is good and bad. Good in that they can get around. Bad is that these kind of things happen, right? So this is the things you have to be watchful and wary of and keep an eye on. So everybody should know a classification. The Wagner class has been the classic one for as long as I can remember, and there's another one, but this is the most classic one with 0 meaning that you see a little area of erythema, you know, a little bit of warmth there, but nothing there yet. And then you get down to 5 where there's gangrene. Okay, and this can apply to anything. On a foot, it's gangrene of the foot, but these Wagners can be on the hips and anywhere else. Once you're down to necrotic, dead tissue, you're at grade 5, okay? So that can be anywhere, sacral area. 2 is probably the one we hover around the most at, and this is the one that we have to be careful of because this is the one that gets to this one, gets to osteomyelitis. And although we have better therapies that we did years ago, it still has to be treated. It's either going to be suppressive therapy or removal of bone, right? So there's not a lot of him and hawing around with this. Somewhere along the line, something has to go. So that's the bad thing. So we try not for the 2s to get the 3s, right? So that's the name of the game. So when you see a superficial ulcer, we got to get it closed fast because if we don't, it becomes a chronic ulcer, and then we start getting osteomyelitis. And this is kind of the way it looks. So it kind of gives you this whole idea of going from a Wagner 0, where you just see some redness here, and then coming down along the line, here's a Wagner 2, not to the capsular structures and not in, but definitely into the fat structure. Here you see it to muscle, right? So now you're in muscle, capsular structure, and then here you start seeing gangrenous changes like you see here. So that's what we're talking about with these things here. So you should grade them, so in that way people know what you're seeing. So when you see a wound, you should be able to say it's a Wagner 1, 2, 3, 4. Try to keep in that wheelhouse that looks like this. So at least when somebody sees your note, they can know if it's getting worse, right? So I always tell that to my residents because they'll just say the size, the depth. I go, well, other than that, or they're taking a picture, we need to have a better way of describing it. So this gives you probably a better overview that, hey, it's a Wagner 2, but now all of a sudden it's necrotic. Well, it went from a 2 to a 4, right? So that's not good. So that's what we want to see. So here's the treatment. So over the years, I've been doing this a long, long time, definitely before 1990. And so when I started, it was everything was getting excised. You had to have a scalpel, a which freehand knife, everything was being cut out. Then we had the age of pressure, negative pressure, that's the thing to go, which is our VACs and all that. And then silver came along, that silver's going to kill everything. Then biologics come, and now we're at regenerative medicine. And so we'll kind of talk a little bit about each one of these things now. mainly staying probably on these sides right here. Still, you have to remove bad tissue. So there's still something about debridement of bad necrotic tissue. It has to go. So what do we see? The diabetic foot wound basics are you evaluate them. Do you culture them or not? So if there's no active drainage, no cardinal sign of infection, so Wagner 1 or 2, you leave them alone. Do not culture them. Why don't you culture them? Because you know you're going to grow something. Probably be some skin flora. Now you got to treat it. You don't have to treat it because we're physicians. You have to treat it medically, legally, right? So you got to protect yourself because somebody's going, oh, doctor, you know, there was this little staph epidermidis laying there. You didn't treat it. And you're like, oh, good Lord. So that's why I have the question mark with the culture, right? Just be careful. If you see purulence, you better culture it, right? It's super deep. Swabs aren't enough. You have to have tissue, okay? That's what the pathology guys tell us all the time. Stop swabbing around stuff, Dr. Ford. Give me some tissue down there that I can stare at, okay? So weight bearing we talked about, metabolic control we mentioned a little bit, circulation we definitely talked about, then the biologics and the antibiotics. So remember, antibiotics will never replace adequate debridement of a wound. If you have an abscess, the abscess has to be opened up. There's no way the antibiotics are just going to cure the abscess and let it go, right? It's got to go. So something has to give with these things. So here we go. So benefits of healing a diabetic wound, we already kind of know. Gets rid of infection, maintains their health status so they do better, prevents amputation, improves their quality of life because they can wear shoes and get around, you know, and absolutely reduce costs because we talked about how much this is absolutely costing our diabetic population in around the 11 billion per year in the United States, right? So wound care, if you're ever bored and you want to come up to wound care, just call me. Come on up. I'll show you everything that's available. So everything from debriding enzymes, calcium alginates, collagen alginates, hydrocolloids, silvers. There's nothing that's not up above that we don't have and have available. And that's just some of the more common things that we use. Then we get to the biologics, which are living skin substitutes, allograft skin substitutes, cryopreserved fibroblasts, amniotic tissue, platelet-derived growth factors. All these things are used. So, and we use a lot of them. We use a lot of them in wound care because our patients sometimes aren't strong enough and metabolically stable enough to take flaps from them or take skin from them, because now we might create a new wound, which is frightening, right? So you're going to go, man, I'll cover this, but I'll just harvest some skin off their thigh. Well, yes, good on a healthy individual. Bad on a patient that is not healthy. Right? So if their albumin level is 2.2, really small, nothing, probably not a good person to do. And their hemoglobin A1Cs, we'll say 10, will make it nice. You probably don't want to do that split thickness skin graft or a flap. So we go to some of these substitutes, which would be amniotic tissue and allograft skin substitutes that grow things in. So they only act to get tissue to get within their matrix. That's how it works, okay? So it is not anything like, my God, this is brand new skin, I'm going to stick it on there and it's going to be like skin. No, it's not like that. What it does do, it allows your body to see it and believe it's skin and then grow into it, okay? And I kind of make a thing like a screen door. You have the screen, you put something up against it, and then things start coming up to the screen. And that's what's happening with these skin substitutes. They have all these little receptors to bring living tissue to it. So that's how it works and that's how it's done. And it works pretty good. So, you know, things to watch out for, and test questions are always this about ulcers, is to watch out for the marginal ulcer, which is a squamous cell carcinoma. Things that haven't healed for months and months and looks weird, it probably is weird and you need to biopsy them. So punch biopsies work great for these things. We catch about one every 6 months from other practitioners and what have you. Says, I'm sending them to your wound care center. I'm sending you over here for you to look at them. I go, okay, what's wrong? Well, they had this wound and it's not healing and it's on their thigh. And I go, how long has it been there for? Well, about a year. And I go, And then when they come in and it looks weird like this, and doesn't look like a normal ulcer, we'll go ahead and biopsy them. You could do no wrong biopsying things. You need a 3 millimeter punch biopsy. That's what everybody wants. And I usually tell people take 2 of them, one dead center and one around the periphery. Okay. So what do we see? So just to give you some ideas of what bugs grow. So we're going to talk non-limb threatening and then limb threatening. So on the non-limb threatening side, staph is the main guy. Okay. And if you go all the way down the bottom, you'll notice that 2 different isolates are in a third of the patients, right? Okay, so it's a mixed flora kind of thing. And that's with the non-limb threatening infections with a foot ulcer, okay? Then we get the limb threatening ones. Staph is back there again, right? But look at the bottom. Now all of a sudden there's more. Now there's 3 organisms or more that are isolated in over 80% of the patients. So not a third of the patients, now 80%, almost all of them are going to have multiple organisms, part of this. And the same, we see it all the time, okay? So how do we treat them? The mild ones, usually orally. So it's usually what you see up here, not too bad. We definitely will have culture to see if it needs to be treated. And then on the other side, it's usually IVs, okay? So hard to get around it. But usually going to be an IV when they are mixed anaerobes and aerobes, and it's a complicated foot infection. They'll be in the hospital and then get a PICC line with the ID docs, and then we send them out after we get them stable. So normally the ID guys will call us up and say, hey, we got something, looks like an abscess or necrotizing fasciitis. Can you get in here in the hospital and get this thing opened up? Yeah, so we'll go ahead and open it up, do pulse lavage, clean it off as good as we can, and then have them start, and then send cultures, and then have them start doing their antibiotic therapy and watching to see if things start subsiding and looking at their labs, right? So if labs start dropping and they look clinically less sick, then we feel comfortable that they can go home, in a PICC line. So that's how we kind of set them up with. So for us, always the same thing when we're looking at talking about diabetic patients. Patient education is key. Tight glucose control, as you guys should know, key. The vascular assessment, really, really important. And then getting them to an orthotist for appropriate shoe gear wear when necessary. Not every diabetic patient needs one. However, every diabetic patient who has an ulcer needs to be in one, right? That's all there is, because they have a chance of having it again. So you have to be realistic about what it is. So if you have a very well-controlled diabetic patient who never had an ulcer, and you test with their Simmons-Weinstein monofilament exam, and they feel everything, and they have normal protective sensation, they have their deep tendon reflexes at their foot and ankle are intact, which would be your plantar response and your Achilles tendon, good to go. If they have none of them, you got to protect them, because they're going to get one of these things, right? So that's the thing we want to be careful of. So it's really important. We keep forgetting about educating the patients, letting them know what they have. But the more you give them, the better off it is. And it's always good to have residents and fellows run around, because, the attendees can go in there and say stuff, but then they get the reinforcement by you guys. You guys come in there and go, yeah, you got to do this, you got to do this. I had a patient like that just a minute ago upstairs who had a dog bite her foot, got infected, ended up with a transmetatarsal amputation, never came back, missing for like 2 months after her amputation, came back with another giant wound, cleaned that out, and has been missing until we just saw her now, which was again for another, I think, 35 days. Didn't look terrible, but we sat there with her and just said to her, okay, this is it. You don't follow back here next week. I'm just calling Dr. DeViti, the vascular surgeon, and you'll be missing a leg. Right? You got to explain to them this is serious stuff. Same thing with her smoking, and same thing with her hemoglobin A1C that keeps rising and not getting any better. So you got to keep reinforcing it and document it, of course. Please put this stuff in your notes at all times. So I'm going to just talk a little bit about amputation, so you guys have this wheelhouse about what goes on and what happens. So a ray resection. A ray is considered to be a finger and a metacarpal, right? And then a toe would be a metatarsal and a toe, right? So those are rays. So second ray would be the second finger, second metacarpal. Same thing with that second toe, second metatarsal. That's a ray. If you remove just part of the metatarsal, that's a partial ray resection. Go away to the back and take it all out is a full ray resection. So here you see a ray resection being done because you can see where it's being cut. That's the cut line of the first metatarsal, okay? So partial first ray, right? So out it goes. So there's a little bit of data about these things and some of the things that have changed over time. Because when you look at the literature that I'm describing here, it's hovering around 2012-ish, 2011. The success rate was pretty good, okay? However, it gets bad when you start having metabolic problems and you start having problems with their vascular tree. So that's where things go bad. So as I always talk with our vascular team is if they come in and they need something, they have to do their intervention first. Once they have things opened, then we feel confident enough when they tell us, hey, we have a Doppler pulse now, you go do your thing really fast so it heals, right? So that's how we do it here at the university. And we've been very good. They have great fellows, and they have a really good department, and everything works out well with those guys and us. Transmetatarsal amputations look like this. So there is the before and the after. You can tell it looks very nice. It looks good, very functional. The things that we learned from transmetatarsal amputations is something we should have known long ago in biomechanics. Biomechanics is that once this is done, the lever arm is shorter and the Achilles tendon contracts. So it keeps on wanting to drive the front of the foot down. So they can re-ulcerate here and create a new problem. So once this heals, we recommend that they get what they call a gastrocnemius recession, which is to lengthen their Achilles tendon from their muscle. By doing that, they can walk on it the same day through an incision of about 2 centimeters on their calf, which allows them to ambulate day one. And we get about 15 degrees of what we call dorsiflexion of the ankle, so they're not in equinus and their foot coming down to get this stuff. Years ago, we didn't. And of course, complications arise, and so that was an issue. So we do transmetatarsal amputation for a bunch of different reasons. If they already come to us and they already have a bunch of rays resected, they have a severe soft tissue infection, not enough perfusion in the forefoot, okay? Those are all issues that you have to address with more proximal amputations. So that's why we do it, all right? And so when you see this here, where it says about transmetal amputation significant complication rate, it was because none of these patients got an Achilles tendon lengthening, and they all ended up getting re-ulceration up in the forefoot. So that was the reason, and that was the reason why. Okay, so the requirement for further surgery was the gastrocnemius recession or Achilles tendon lengthening. So here's different other ones. So this is what they call Lisfrank's amputation, right across here, what they call show parts. And then when you get right around here, same thing, okay? So show parts amputation, Symes amputation, pretty close to each other. Symes is really like almost everything missing. There is no cuboid. This is where the Symes would be. So all you do is have the part of the talus, part of the calcaneus, not very functional at all. Some people refuse to have their foot amputated, and it's done. I only know 2 people here in the city that do it. And now they're stopping to doing it because their outcomes are poor, and they still end up with that. This amputation here is not bad where you get across Lisfrank's. It actually works very well as long as you do a gastrocnemius recession or Achilles tendon lengthening. That all has to be done. And again, we always recommend it being done after all this heals. That's enough surgery. They don't really need to have this stuff go. And most of the time we're doing it because there is some infective process, and why create more infection, right? So you want all this stuff to go away. All right. So, and as I mentioned, these actually do very well. They do actually very well. So a lot of different amputations you can do, and this is a Lisfrank's amputation. You can see fairly long foot, still looks pretty good. It can get in a shoe. And people say, well, you're missing all your toes, and I need balance. You don't need your toes. You will be unbalanced. But we do give them a shoe filler. So we get them a specific shoe, it's an insole, with where their toes would be. So this part of their foot would be a butted up, a filler, which would look like one when you have like a below the knee amputation or an AKA. They fill it up against it. They can use all kinds of different materials. Okay, it could be spongy material, or it could be a viscoelastic material that they put inside the shoe to protect that area. But that way they don't have a crack in their shoe and they can walk a little bit more normally. So we do that all the time. So here's Brown's report and the ambulatory level on Charcot disarticulation. So pretty good. Okay, that was 2012. And here's what I'm talking about, Achilles tendon lengthenings. So this is the old way we used to do on this side. This is a gastrocnemius recession where it's cut way back here. This is an Achilles tendon lengthening where it's done through these 3 percutaneous incisions. One through here, one through here, and then one through here where it's incised. We call a triple hemisection of the Achilles tendon, which goes right down the midline of the Achilles. It's cut this way in half, then this way in half, and then this way in half. And it will lengthen your Achilles approximately 8 degrees. This does 10 degrees, and they can bear weight on it the same day. So we lean towards more of this. Rare that it's done right here in the posterior side. Now it's done through a little medial approach on their calf that is about, like I said, 2 centimeters in length, so very small now. And it can be done endoscopically as well. So just to let you know. So the LEAP program, which is Lower Extremity Amputation Prevention Program, this is done by the ADA, and they recommend an annual foot screening. They recommend patient education yearly, appropriate footwear evaluation, the patient to be doing daily foot inspections, and management of simple foot problems. They should know what they need to do or not to do and where to seek attention from. So here's my collaborative multidisciplinary wound model. So this is where you see kind of all the things that should be going on in our diabetic patients, right? So the selected pathways are all these different pathways we have, but endocrinology, PCPs, podiatric medicine, plastics and general surgery, orthopedics, orthoprosthesis, infectious disease and vascular surgery. These are our main focus people. And then after that, physical therapy, home therapy, and diabetic and nutrition counseling. Send a lot of people to nutritionists to get counseling. And I think it's necessary, especially when you run their labs, especially when their hemoglobin or, the albumin levels are low. So we try to really kind of look at them as a whole and not just, I got this little ulcer and we can make it heal, right? So got to look at them globally. So you need a lot of people to make this thing work really well. So we also use hyperbaric oxygen. The hyperbaric chambers are up there. They were initially used for the Coots and Kleinert hand group for their crushing injuries that they would get and radial anoxia of the hands, and when they did their hand transplants. So but now Medicare, Medicaid, most insurances will pay for hyperbaric oxygen therapy for diabetic wounds as long as they've been out for more than 30 days. So if you can't see any progressive healing, they'll allow it. So we have managed these chambers as 100% oxygen. And it does a few things that are important. You know, it provides angiogenesis to tissues, which is good. So when we see failed flaps from the plastic surgeons, or we see, failed flaps from our service, it could go into a hyperbaric chamber. Those are considered to be indicators for hyperbaric oxygen. Of course, the anaerobes don't like it, so it's a good thing when you have some of that. So carbon monoxide poisoning, the basic things that everybody knows, great for. But in the wound world, it's now available. So we do use it. There's 2 chambers, and we do use it fairly frequently, usually about 10 sessions, which is 2 weeks. We do it Monday through Friday, and then they come back, they give them 2 days off, and then Monday through Friday, which is 90 minutes inside a chamber. So that's the way it happens. Okay. So, and then I got a few more. So this is just my conclusion for this part. I'm going to talk about Charcot for a little bit with you guys too, because I think it's important. Hence, you see the Charcot slide there. So I think my big thing is we need to reduce our hospitalization of these diabetic patients. It costs a lot. And we need to have a better team approach with multi-specialty people, which will optimize our patient and get them out faster, right? And so certainly you guys should be right in that game with us. So Charcot, what do we see with this? How many people have seen Charcot arthropathy? Anybody? Yeah. So Charcot arthropathy looks like this. It gets misdiagnosed a lot in the ED as probably osteomyelitis. So they see destructive changes there and they're freaking out. because the foot's warm, hot, and swollen, and now all of a sudden it's infected. But you run all their markers and there's no sign of infection, right? So white cell count's normal, everything else is normal. But they're staring at you and you're asking the patient, how do you feel? Fine. No temperature, no nausea. Nope, good. That's probably going to be your Charcot. You got to kind of look at it really hard to make sure you're picking the right way. So you can see it could come out to about 7% of the population with diabetes have it. So it gives you that route number of about 120,000 people per year. So we're looking at 30 plus million diabetic patients in our United States. So a lot. So when you come down to here, it's a late effect of diabetes. So it's a sequela that we see from trauma, and that trauma is usually repetitive force where they can't feel anything. There's two systems to it. Some people, the French system, which is the neurovascular system, and then there is the repetitive microtrauma, which is the German system. Both of them are pretty much working together. You can't have one without the other, right? So we understand when you can't feel anything, but you're having more pressure to a site. Well, that repetitive pressure to the site is the thing that breaks down bone. So that's how it works. So interestingly, these patients have great circulation. They might have mockingbird sclerosis on an x-ray where you see hardening of their arteries, but I am telling you the blood is coming down there. And so anybody who has been out in a river and in a lake and picked up a log that's been floating around in there for about 4 years, and you pick it up and you drop it, you see how it explodes everywhere? That's what happens to these diabetic patients. It is all this shunting and vasodilation going into their extremity that truly just breaks apart their bone. Yeah. So both, like I said, kind of contribute to this pathology. There are classifications. Eichenholz is one. Bob Fragberg and Sanders did theirs, again, back in Texas. Texas must have a lot of diabetics. So this is the Eichenholz staging, which is the acute stage, the coalescence stage, and the consolidation stage. And you should know what they look like. So let me see if this will click over. Here we go. So that's a foot. That would be something you should be concerned about because you see this bone should be here. And it's not. This bone's hanging off here. So here's the beginning. This is the acute phase. It's foot's red, swollen, something funky when you take an x-ray. Not bad. Then you get to the quiescence phase where it's kind of just calming down. Things are stabilizing. Bone's growing around. Now you see the bone kind of growing around everything till finally you get to the phase where it's all kind of just here. All bony stuff is together and ready to go. Okay, they go through phases, and the main focus for this thing is to immobilize people. This is the most common spot, so the Lisfranc's area. And mid-tarsal, probably the second, forefoot, third, and then the rest. This is the least common that we'll see, okay? But if they ever ask you a test question, this is where you see it most when you're talking about the anatomic classification of Charcot. So again, clinical presentation, red hot and swollen, painless, because most of them can't feel anyway, right? You might feel some crepitus moving the foot around and you'll feel some hypermobility. They can't feel anything. Everything's usually missing, so no deep tendon reflexes, no protective sensation. But like I mentioned, bounding pulses, right? So really, really, they're palpatable. And then bony destruction, joint subluxation, and then bony remodeling. So that's the thing we look at when we see Charcot. And can you stop some of this? Yes, you can stop if you get it early. The problem is sometimes you don't get it early enough and they're already into their consolidation phase. The acute phase is where we want them. So that's where our osteoclastic activity is going on and bad things are going on. We try to avoid this from happening because this is not a good foot to bear weight on. It's hard to put a shoe on this. This you have to reconstruct. So we don't want to do this. But on MRIs, this is kind of what it starts looking like. You can start seeing this discoloration, just the whitening of the bone. So we know it's being resorbed compared to the dense bone you see around here because of all the fluid coming down into this. All right. So goals. What do we want to do? We want to restore stability, prevent the amputation, prevent infection, prevent ulceration, and make them be able to wear shoes, right, and get around. Ultimately, the initial treatment is immobilization. We'll talk in a second about some other things you can add to that, okay? So immobilization, a crow boot, I don't know how many people have heard that, but that is a Charcot restraint walker. I'll show you a picture of it in a second. A patellar tendon brace, an AFO, and custom molded shoes. These are all things that we use. We usually start with this and then work down to this. Okay, so they're in a crow boot and then a custom molded shoe if their deformity doesn't go too bad. That's what a crow boot looks like. So it's a giant clamshell, lined perfectly, fitted to the foot that they strap on and they leave on. And you can stare at the foot as much as you want, which is nice, okay? Again, total contact cast, we still use those for these things because it reduces a lot of pressure and they can't take it off. And that's what a total contact cast looks like here. And here it is going to be put into its little weight-bearing guy. Bisphosphonates. Don't want to forget about talking about that. So we do use some of them. The second one, Areta, is one that we'll use every now and then. It is an IV. You have to inject it about 90 minutes because it takes about 3 hours for it to go, and it's a very slow process. But it does stop osteoclastic activity, mainly used for Paget's disease, but about 2010, they approved it for Charcot arthropathy. All right, so we get an infusion lab, and if we see it early and they haven't broken down much, we absolutely try it. Okay, Fosamax and some of the other things are okay, but not usually strong enough for it to do what it needs to do to quiet it down. So usually one of the IVs over 90 minutes, and then they're usually good. And then we're kind of done with these. And it usually quiets everything down until we can get them in a shoe. Surgically wise, this is kind of what we have our wheelhouse with. It is ostectomies, fusions, osteotomies, Achilles tendon lengthenings, and soft fusions. And soft fusion will kind of show you a bunch of different stuff. Here is a ulceration on the bottom of the foot secondary to this. So that is causing this. And then you see the rest of the foot up in the air. And this bone coming down this direction, which is the talus. And here you see it just morselized and crushed on the side of the foot. So the goal is to get all this back that direction. And you can do it with multiple different things. This is what they call a beam, and that beam comes into a metatarsal intramedullary, all the way down into the hindfoot, and a large plate with screws to take all this and bring it that way to line up the foot so you have a straight foot and none of this here, and all this is gone, okay? External fixators. External fixators are nice when you have concerns about patients. If the bones are mobile enough and they're loose enough, these are through fine wires. They're very small. We can adjust them anytime we want to. And put tension on them to pull the foot in any direction. We can pull the foot this way, that way, backwards, frontwards. It can go anywhere we want it to go. We can invert it, evert it with the frame. And there are a couple motorized ones that do it even better. But this is a simple one and easy to pull it on and fast and reproducible if patients are willing to accept it. So a lot of patients don't want to have that on them because it freaks them out a little bit. Okay, we call cage rage because it is a giant cage pinned into their foot, but a lot of them are like, yeah, I'd rather have that than lose my leg, and so that's that. And then, as we mentioned before, the Achilles tendon is so important in all these patients. No matter what, when I see a person with Charcot and they don't have much of a problem, but they're in equinus, I always recommend to them a prophylactic gastrocnemius recession so they avoid a lot of these things in the future, right? Because it puts too much stress on the forefoot and midfoot by being in equinus. So we always recommend that when we see them and it's not too bad yet. So here's a good survey. I pulled this one out just recently, and this is, from your guys' journal. So read what it says about what they're finding, and this is from, 400 respondents of ID, family medicine, endocrinologists at the University of Michigan, so who didn't know much about it. And to be honest with you, I give the same talk, not the same, but very similar to the ED department. And I talked about this, and they're like, yeah, we always think it's infected. We don't even think about that kind of stuff. It's we'll run an MR scan, it'll show crazy stuff, a fragmentation of bone, and automatically are moving towards that, lead of this. Then we have to go there and try to convince them that it's not. So I think it's better that we start knowing a little bit more about it because you're going to see it and we have to deal with it. And remember, the earlier we get it, the better chance of them not having to have surgery, right? And that's the goal. The goal is, man, if we can avoid these kind of things, more power to us, because then they can get into a shoe and have a happier life and move on. And then finally, super challenging, again, multidisciplinary approach. It takes a lot of people to help out to do these things. And I think, to optimize our patients and optimize the outcomes, we really need to see, their sugar levels low, their hemoglobin A1 low, their albumin levels low, and to make sure they have good pulses and that their vascular tree is intact for them to be able to get around. So it takes a lot of people to be involved in this. Here's my dogs. Just anybody want to see these guys? And finally, this is your event code that I was told to bring up. I think I'll let everybody get their event code really fast. And then I'll stop sharing the screen in a second. And then if there's any questions, feel free. I see somebody's asking something. Got it? Got a chat guy. Anybody have any questions?
We have plenty of questions.
Good.
Thank you, Dr.
Go ahead.
I'm Satya Krishna. First question was shock because you.
Yeah.
So yes, it comes in the internal medicine.
Yeah.
All kinds of books, so usually. My question was this: for diagnosis other than clinical evaluation, I wouldn't do that. We don't do MRIs because by the time I wait for getting a prior approval, I just do a plain film, like bag of bones, and then I've used Reclast, which is the infusion we use for
Sure. Yeah, or 2.
5 milligram. But my question was the length that you had. We use a 60-minute. We have it already set up in the infusion center in the basement.
Yeah.
In HCOC, we do 60 minutes. But you say 90 minutes?
Yeah. And I think it was because like a lot of the things that are being infused into people, they're getting reactions and they don't want it.
So it's because of the reaction.
Right.
We have that all figured out.
Yeah.
The says 50,
right.
60, so.
And again, based on their body mass as well, what you're going to give to them too. So I think it's those 2. Huh? Yeah. Yeah.
Oh, okay.
Yeah. So. Yeah. So. Yeah. So we're using Iridia.
That's Pemitrone.
Yeah. So pretty much that, and that's really based on their body mass, but it certainly goes from about an hour to maybe 90 minutes.
Yeah. Pemitrone has longer. So,
but anything that stops osteoclastic activity is good. Like I said.
Intravenous.
Yeah.
So I guess.
Yeah, because it's just more direct. Spraying stuff in your nose and taking a pill is probably not going to get there fast enough to be where you want to be now.
So my second question was toenail. I know I missed the first 7 minutes. So many times, cosmetic and is the fungal toenails, and then some of them they're bruised and they've gotten discoloration.
Sure.
But 6 months later, it didn't still go away.
Yeah.
And they may be on baby aspirin, but not like major anticoagulation. So how do you deal with those and ingrown toenails? That is of a more common issue.
Right. So for deformed nails that are creating a problem, the choices are debriding them down to some healthy level, which is the first thing to try, and putting them on topical drugs. So we usually won't give them the oral medications, but there's a lot of different topical. The same orals that you can take for fungus are available from compounding pharmacies, and we use a lot of that. The orals have a lot of side effects, as everybody knows. It's liver side effects and everything else. So we kind of we'll use them, but they got to be younger patients and not with any kind of diseases. So, and then the alternative to that is avulsion of the nail, like just remove the thing. And then again, because the organism's in the nail plate, getting into the nail cell, and so it's a battle that you can't win. And if their status vascularly is good enough, they can be removed, and then they can treat locally over the nail bed with antifungal topically for it to allow it to grow out more normally. So that's what we'll do. So we give them 2 choices. We say to them, here's what we can do. Again, I'll verify the fact that they have enough blood flow. If they say they are and we say they are, and I go, okay, we can remove your nail, let it grow back. That's what you have to do. Or we can remove it and not let it grow back. You tell me what you'd rather do. Some of them just never want to see it again, and they just want that nail killed off and can care less. Some of them want to try to see if it will grow back again, and we say, fine, this is what we do. Avulse the nail and then give them, believe it or not, just any over-the-counter antifungal cream to put over the nail bed. They do that twice a day until we start seeing new nail growth. Because we just don't want, like clotrimazole and all those work just as good when there's nothing there, because all you do is have the nail bed. Yeah. So those are things we do.
The bruise and hyperpigmentation.
So there are some things that are.
Do you worry about melanoma?
Yeah. We just had one, a matter of fact. So that streak has to go pretty far back and go back into beyond the nail fold, and you should be able to push back there and look to see. If it's truly a fungus nail that's certainly big and it's probably just old blood that's underneath it, or it's just a darker fungus material that's showing up. Streaks that come down longitudinally right down center in a normal looking nail are the ones that we start having concerns about. Yeah, we can start thinking of all kinds of different, things that can create it. But the bottom line is we tell everybody they need a punch biopsy. So we get a biopsy of all of them. So
what is the length of time you?
I ask them how long has it been around for and all this, and if they say it's been there forever, then I usually don't worry too much about it. If they say they just noticed and they don't have any history of trauma, but even shoe trauma can create these things. So you got to remember, they can bang their toes into things, they don't feel anything. Next thing you know, got blood back in the back of the nail and it's growing out with black. There are enough funguses that are organisms and yeast that will look black in the nail. Yeah. So I usually don't get concerned when it's a super thick looking nail. I only get concerned when it's a normal looking nail with a streak going through it that's longitudinal, going from the posterior nail fold going outwards. And I see that, I go, I don't like that. Yeah. And we'll probably see, melanoma Whitlow and a few other ones, which are nail ones, probably 3 or 4 times a year. Yeah. Yeah, and nobody looks at it and I go, yeah, how long have you had this? Only maybe 4 months ago. Well, you got to do this. Okay. Yeah. So the punch biopsy is not too bad, so we can get them out. So it's usually normally along the nail fold back here or dead center of the nail. It's one or the other. Yeah. You're welcome.
One of the things that we have
Mm-hmm.
it looks like there is a lot of become less and less. So how do we address that issue? Even now, even like the VA used to have a nail clinic and they took that away.
Correct. Yeah.
And we have this problem. They themselves cannot do it, and we also don't want them to do it.
Correct.
So how do we address
So there in our city alone, there's like 4 community guys that do it, and in our group 2 that do it. So just to let you know. Mm-hmm. All right. It really came down to the fact that the insurance carriers just said, we're not going to pay for any more of this stuff. Too bad for you. Just like they did the diabetic shoes. So our big lab, Anger Lab here, which we used all the time, no longer do it because they could not get the referrals from their PCPs, verify the fact they had diabetes because that's where it had to come from. Couldn't come from me. If you're not prescribing their medication, couldn't come from you. It actually had to come from the prescriber, whoever is writing the medication. So it got so frustrated because it got so convoluted, which is stupid, right? You should be able to write for it. I should be able to write for it. Family practice guy should be able to write. Why can't they? I don't understand. We're just verifying they have diabetes. They have lack of protective sensation. Okay, should be good enough. Well, evidently, no, that's not good enough. So I think it was that stopped that. It was very similar to what happened with all this nail care stuff because one minute it was fine and the next minute they just, like the IRS come busting through your doors going, well, show me every documentation of why this person needs to have this. Where's the note from the primary care doctor that says they have diabetes and you're allowed to do this? It's almost like the fact that you have to have a referral and that referral has to state that you can do it, then you can do it. It's absurd. So that's why everybody started going, I don't have time for this. They just got frustrated. But like I said, 5 community guys, 2 in our practice, they just said, you know what? We're making time. We don't do it all the time, but I specifically set this time down for this kind of stuff to get done. You know, we have people here to help us, which are medical assistants, what have you, and they take care of that stuff. You know, and then, you know, for the most part, they almost invariably know that they're not going to get paid, but they just go, I'm just going to do it. Yeah. So they are, which is good. So that's your answer. Yeah. So we still have some.
I have another question. More recently, the last 5 years,
Mhm.
this new, the great group of drugs which everybody wants to, diabetics on the SGLT2.
Sure.
You know, Jardians and Invokana and Poxy,
Yeah.
to name a few. So early on in some of the studies, there was some concern for toe amputation being.
Yeah.
So have you seen that?
To be honest with you, I haven't seen it as much as what I've seen it, but I've not seen it like, oh my God, I really don't think it's from that, like Jardius or any of the other ones. You know, for our purposes, for the most part, it's usually, my God, they're just, you know, they get a wound and they just never get it treated, or it gets out so long that, you know, we made an appointment for you and they cancel their appointment, cancel an appointment. By that time, you know, they got gangrenous changes and now you're, you know, there's nothing else you can do. So they end up with the amputation. But I really haven't seen that. Okay, which is good. But yeah, don't need more amputations.
Question there. Compression stockings help.
So compression stockings in themselves don't really help unless they have, you know, venous insufficiency, things like that. They need to be pressure graded. So, you know, you need to know how many millimeters mercury pressure you want to put on these people. You can't do it with people with CHF. So there's a lot of people you can't do it for. Can't use it on our VAD patients. So just FYI. So there's a lot of patients you got to be careful about compressing. But we do use compressions, especially for venous wounds and things like that. So you're going to have a lot of venous leg wounds, venous stasis, and so compressing is great for that. But really, it's not going to do anything for like diabetic wounds or any of that stuff. Yeah.
One of the big problems really
Mm-hmm.
going to different.
Right.
You know, I mean, either if they're coming to us with a foot problem, they haven't.
Right.
Easily,
Yeah.
you know?
Yeah.
And the other way around, if they're going to you, they're not.
Sure, sure. So one of the persons that I mentioned is at the ambulatory care building. He's there every Friday morning now. So one of our former fellows is now one of our attendings. So he is there and he does that. So he's always there. And there, he also now is going to Cardinal Station, where there's a place out there too. I don't know how many guys go out there, but he's going there too. So there's like at least a neck here, because you guys are here. He's here on Fridays. And we send tons of different people for this. So, and more than happy to do it. So, yeah.
And for vascular assessment, what is the thing that you?
So our first thing is we get ABIs on them. So always an ABI. So wound care, that's our initial thing we get is an ABI from it. Once, if we see anything weird, then off they go to the surgery department and we have those guys assess them and decide if they need to do anything more. They might do a CTA and some other, you know, testing on some of these patients to make sure they have it. But for the most part, when we see something that's dusky or changing colors, or we can't physically palpate pulses, and you get a Doppler and you really still can't find anything, you got to send them out. And so, because again, if they didn't feel anything, they're not having pain. They're not like in critical limb ischemia, like patients who are smokers who can feel stuff. Will complain like I can only walk like 2 blocks here and then I'm crumpled and ready to fall down. These guys can't feel anything, so they don't even know they have it until they see something changing color on their skin and getting gangrenous changes. Then all of a sudden they're like, now it's too late, right? So I think for us, when we see them initially, for us, it's always the same thing. And when I do this for family medicine, same thing. I say, guys, get their shoe off. Every diabetic patient, feel pulses. At minimum, just tell me they got pulses. Feel their dorsalis pedis, feel their posterior tibial pulse. If you can't feel them, if you have a little Doppler in your office, great, put it on and see if you can find it. If you can't, send them out someplace to find out what's going on, right? So, and, Dr. Davidi and their group told me the same thing. He wanted, hey, man, you see these people and you can't get pulses, maybe get ABI before you get them to me. But, those guys are really efficient. Like if I call him, like today, if I take a picture of patients, like he'll be seeing them tomorrow. It's crazy. It's insane. I don't know how he does it. Yeah. So, but that's good. Those are the kind of things we need because he knows that bad things can happen, if things wait for another 4 days, right? So, plus for us to have somebody that good who wants to do it. Yeah. Right. And we do the same thing. So it'll be our clinic here at the university. I said, I got to go over here.
Yeah, not be. It had and this, and I could definitely.
Yeah.
And by radiologist, private practice, interventional radiology. What are your feelings about like an independent radiologist putting in a stent versus or any vascular surgery?
Yeah, I mean,
I've never seen that before.
Yeah. So interventional radiology, interventional cardiology, they all do it. So I'll tell you that now. When you talk to the vascular guys, they say, well, when it hits the fan, they have to go in and fix everything. So that's the difference. They can't crack anybody open. They can only get a fine wire and go down an artery and try to get things opened up. So there probably is a succinct difference between, that. Not to say that there are not some really, really good interventionalists, because we do have some very good ones. And even Davidi had some on his own team because he didn't have the time to do all this. And I think he still does have some people that help do his stuff. Okay. So I think that's absolutely good in the right hands. And it's all about time. If it's something that they do a CTA and they think, well, hell, here's this occlusion here and I can open it up with a fine wire, then why not? The cardiologists are doing it every day, in the hearts. And so why can't they go down a leg and kind of do the same thing? And for the most part, I think that we have some very good ones. So I don't get too concerned about that. It's just like if they really have bad vascular disease, they really need to see a vascular surgeon because a lot of them sometimes just need bypass. Yeah, I mean, it gets beyond that.
Like for
yes, yeah. So yeah.
Like,
so
all around the same. Some patients have this,
right.
Chronic
right.
stasis dermatitis, and along with that, the foot issues.
Right.
And the blistering.
So that center, it has general surgery, podiatrist. I don't know if you know Carmen Akhtar, who's an infectious disease doc. He's there. So we got a lot of different, specialties there, just looking at patients all day. So it's good. So we have enough people to fulfill that. And then Dr. Davidi and his team are pretty much, he was coming too much, he can't be. So now we just refer, we say, but we refer like that day, he'll take them right away. Yeah. So that's how that works. So it works out good either which way. And sometimes if he's, how he is running over there to Norton and he's over here and then he's down over at Jewish, if he's on his way somewhere, he'll just stop by and find out what's going on and keep going.
To be careful, you don't know what him because
yeah, it's crazy. So you're welcome. Any other questions, anybody? No? All right. Well, thanks, guys. If you have any questions, I think somebody has my email, feel free to email me. Okay? All right. Thank you all.